Good morning, everyone. Welcome to today's episode of PYA's Healthcare Regulatory Roundup webinar series. Today's topic is 2026 Medicare Physician Fee Schedule Final Rule, Part 1. PYA is happy to present today's webinar on this important topic. You may submit questions during the webinar by typing a message into the Q&A pane of the control panel. Also, immediately following the end of the webinar, you'll be asked to complete a short survey and submit any additional questions and comments. Any questions posed during the webinar will be responded to via email after the webinar. You can customize your viewing experience by resizing, moving, or minimizing all of the panes within the webinar.net platform. We've posted a PDF copy of the presentation slides for your reference in the Resources pane. Also, you'll receive an email later today with a copy of the slides and a recording of the webinar. With that, I would like to introduce our presenters, Marty Ross, Sarah Bowman, and Lori Foley.
Thank you, Jennifer, and thanks everyone for joining us today for part one of the Medicare Physician Fee Schedule Final Rule webinar series. You see what we're going to cover today on the left-hand side of your screen, and we'll come back a week later and cover those topics that are listed on the other side. Without further ado, let's get to the money and what we're going to get paid this year under the Medicare Physician Fee Schedule. Of course, good place to start orienting yourself is where are the rules orient of how the physician fee schedule payments are calculated. That goes back to the Medicare Access and CHIP Reauthorization Act of 2015, more commonly known as MACRA. That legislation replaced a pre-existing formula for physician payments that had created a number of problems over the year, resulted in Congress having to step in on an annual basis and adjust the fee schedule amounts to ensure adequate reimbursement. That methodology was replaced with specified annual payment increases. As you'll see now going into 2026, we are in the phase under MACRA where we have a split in the amount being paid to physicians, depending on whether they are a qualified alternative payment model participant. Those that are advanced APM participants will see a 0.75% increase under MACRA. Those who are not see a 0.25 increase under MACRA. MACRA also created the Quality Payment Program, or MIPS, as it is frequently referred to as the Merit-Based Incentive Payment Program. So that is our starting point for when we talk about the fee schedule. How we calculate fee schedule payments using the formula from MACRA is dependent on a conversion factor. And it is the conversion factor multiplied by the relative value units, or RVUs, assigned to a specific service that gives us the national payment rate. The conversion factor is determined based on a predetermined statutory cap on Medicare physician fee schedule spending, divided by CMS's projections on the number of RVUs that it expects to be billed during the upcoming year. So really the conversion factor is simply how we divide the pie up among the various services. For 2026, again and beyond, that conversion factor is going to be increased by a statutory 0.75 for advanced APMs, 0.2.5 for everyone else. Remember, unlike all of the other Medicare payment methodologies, there is no adjustment for inflation in the Medicare physician fee schedule. It's simply a statutory number that is applied year after year, regardless of what's happening with costs to deliver those services. One factor that comes into play that does result in adjustments to the conversion factor is the budget neutrality requirement. So if CMS makes policy decisions as part of any final rule that would result in an increase or a decrease in anticipated annual Part B expenditures to the tune of more than $20 million, it is then necessary for CMS to do an adjustment to the conversion factor to ensure budget neutrality. So if we're going to have more RVUs billed as a result of a payment change, then you're going to see a reduction in the conversion factor. If we anticipate fewer RVUs being billed, then you'll see an increase in the conversion factor to ensure budget neutrality across the board. And those policy decisions can be CMS determining that it is going to or not cover a certain service. It's going to limit when a service is going to be covered. These can also be the result of RVU adjustments, CMS determining that it had over or undervalued a service over a period of time, and so it adjusts the RVUs, and that also impacts that total pie and how we divide it up. So over the years, it's been sort of a rough road since 2021 in the Medicare physician fee schedule. As you see, we've actually had a year-over-year reduction of 7.3% of the payment received by physicians. And again, you see on the slide a comparison to the Medicare Economic Index. The inflation rate for medical services certainly is going up and up and up as each year reimbursement of the fee schedule has gone down and down and down. Finally, we see a reversal of course in 2026 with the conversion factor. For calculating it, we start with what the 2025 conversion factor was. That's $32.35. We apply that MACRA update we discussed previously. So we end up for the first time with two conversion factors. Again, one that applies to qualifying APM participants, one that applies to everybody else. To those rates, we then apply the One Big Beautiful Bill's one-time 2.5% increase in the physician fee schedule rates. As you may recall from this summer, when we were debating the One Big Beautiful Bill, there had been proposals for a permanent fix to the physician fee schedule to avoid this issue of continually seeing decreases in reimbursement. But when the bill made it to the Senate, we ended up with just a one-time 2.5% increase for 2026 only. So that gets us to the second set of conversion factors. And then finally, we apply a positive budget neutrality adjustment of 0.49%. The actual proposed adjustment had been 0.055, so it's slightly lower. As a result, the final conversion factors are about 2 cents less than CMS had proposed. So that positive budget neutrality adjustment is unique, something we have not seen historically. Last year, for calendar year 2025, there was a very slight positive adjustment that had been proposed by CMS. But in prior years, it was typically a negative adjustment. So what that means in the policy action that CMS has taken, it has either reduced coverage for services or it has changed the value of services such that the RVUs are lower. So again, CMS is anticipating that decline in the number of billable services, and thus budget neutrality ensures then that the conversion factor is increased as a result of that. For this year, what's driving that positive adjustment is the efficiency adjustment that Sarah is going to discuss. Also, the behavioral health work update in the third year of those updates, some reevaluation of specific codes, and then supply and equipment pricing updates are driving that. In terms of winners and losers, almost all specialties as a whole will see between a -1% and +1% change in allowed charges. Again, as we will discuss, there's now going to be a significant difference between a facility-based physician and an independent physician practice in how they are reimbursed. But overall, the specialties see about a -1 to +1. The exception to that are behavioral health practitioners because of that final year of their update to their reimbursement. They're seeing a 3 to 4% increase this year. Finally, of note, when it comes to the conversion factor, we also pay attention to the geographic practice cost indices, or the GPCIs, as they are frequently known. These are payment adjustments that are made to account for cost variations across 108 specified locations. So if 1 is the national average, that's where we get the national payment rate, that CMS makes 3 separate adjustments to determine the rate that applies in each of those 108 localities. There's a physician work gypsy, a practice expense gypsy, and a malpractice gypsy. And again, all those are adjusting for geographic differences. What's happening this year is CMS is updating the data that it is using on which to base those adjustments. And it will phase in those changes over the next 2 years. There are a change here and a change there. So be sure that you look up in Addendum D your specific locality to see how those gypsy adjustments potentially are going to impact your reimbursement. Also, CMS refers now to the work gypsy as a temporary gypsy because of the 1%, the 1.0 floor. Well, let's try that, explaining that a little better. For any locality that is below 1 for its work gypsy, physician work gypsy, Congress has artificially increased the reimbursement so that everyone is at least at 1. So as a result, those practitioners who are located in areas that have lower physician work costs are actually seeing an inflated payment under the Medicare physician fee schedule. Our issue, of course, is that adjustment by Congress is one of those temporary extenders, meaning it expires after a certain period of time if not renewed by Congress. The most recent renewal was as part of the legislation that ended the government shutdown. It retroactively extended the work gypsy 1.0 floor through January 30th of 2026. And so CMS, when it was calculating the tables, did not include the 1.0 floor with the anticipation of the expiration of that adjustment. So it's one of those things we're going to have to watch, one of those many things that we're going to have to watch as Congress moves forward with deciding how they're going to fund the government from January 30th through the end of September. So one of those many things we need to pay attention to. So with that, I'm going to hand this over to Sarah to talk about the efficiency adjustment.
Thanks, Marty. So the efficiency adjustment is new for 2026. This is not something that we have seen in the past. If you were with us over the summer when we talked about the proposed rule, a lot of these components have stayed the same despite a lot of comments that CMS received. They're moving forward with this efficiency adjustment. And this efficiency adjustment is important for a number of reasons, which we'll talk about in a minute. But when you think back to that Venn diagram that Marty showed, we have the 3 components of the total RVU. We have the work, we have the practice expense, we have the malpractice. So effective in January of 2026, we will see this efficiency adjustment take hold, impacting that work RVU component of the total. So this will be impactful for providers when we think about reimbursement that Medicare will provide, because it's impacting the total RVU that is the component of that equation that gets to total reimbursement under the Medicare physician fee schedule. It'll also be impactful for providers that are employed and compensated on a work RVU basis. So what is CMS's reason for this new efficiency adjustment? So historically, CMS has relied on the AMA RUC committee, the Relative Value Scale Update Committee, to take into account information from various specialty societies as to the time and effort associated with a particular service. So specialty societies will conduct and complete survey information saying this is how long it takes to do a particular procedure or see a particular patient. And those time estimates have long been thought to be somewhat heavy, but they're also have historically been the only, I'll say, standardized source of truth that we've had to rely upon. So those surveys would look at time and work effort in a couple of buckets. So it would look at the pre-service time, the intra-service time, and the post-service time. So pre-service, think preoperative. It's easiest to think about this, I think, in procedural terms. So think about pre-op time spent getting the patient ready for surgery, the decision for surgery. The intra-service time is truly that time that the patient's being, in the OR, the procedure's being conducted. And then that post-service time is immediately after the procedure, follow-up visits that might be needed if the patient is admitted, and is seen in the hospital for a few days, so on and so forth. Those components would make up the total time. And so CMS has said, gosh, this is really heavy. The respondents in these surveys have become lower and lower over time. So we've got fewer physicians responding. And then of the physicians that are responding, there was concern as to potential bias and why are these physicians responding instead of perhaps some others. And so again, if you were with us when we talked about the proposed rule for 2026, I think I used the analogy of my son and we load the dishwasher and we have different time estimates as to how long that truly takes. Some of that bias exists. The truth is probably somewhere in the middle. He's in middle school, so everything takes a really long time if it comes to chores. And some, he would argue, well, I've been doing it for a really long time, so I'm quite proficient and I'm fast at doing it. So some of that same type of bias and rationale, exists when we think about the time study data that we're getting from the RUC. And so CMS has said, we're gonna change how we look at this. We're gonna first do an efficiency adjustment to kind of counteract that overstated value that may have happened and has continued to happen over time. And so the CMS feels that the intra-service portion of that physician time has become more efficient, and they want to take that into account. So this efficiency adjustment is the way that they have decided to do that. It's important to note when we think about all of the thousands of services that make up CPT, that make up services that the Medicare physician fee schedule will reimburse for. There are a number of time-based services, so services that are billed based on time today that are excluded from this efficiency adjustment. So it's really important to understand what is excluded, because there are a lot of services that are included. So excluded services include, that's a terrible way to say that, the services that are not included in the efficiency adjustment are E&M services, care management, behavioral health, telehealth, and then maternity service codes that have that MMM global period. So this methodology, CMS looked at the past 5 years of the Medicare Economic Index, or the MEI, to come up with a productivity adjustment percentage. The MEI is a measure of practice cost inflation. So it looks at non-physician employee compensation. It looks at the cost for rent, medical equipment, all of those various costs. CMS did a 5-year look back and came up with a 2.5% reduction, or a 2.5% efficiency adjustment percentage amount for 2026. So going forward, they have said that they're going to move away from this survey data because of the bias and the low response rate, things that I had mentioned. And they're going to continue to look for other empirical sources of data, other empirical studies and surveys and data collection efforts over time. That is their goal. It remains to be seen kind of how all of that will play out in the future, obviously. In response to a number of comments, they have agreed to finalize a list of specific CPT codes that are going to be exempt from the efficiency adjustment, but we understand those codes will be those services that I mentioned previously. So that is important to watch for and think about as you are projecting what might happen, again, both from a work RVU perspective and also from a total reimbursement, total collections perspective. The other thing that's happening in 2026 is a pretty material change to the way that the practice expense is being looked at. So a change in the practice expense methodology. So currently, and in the past, CMS has relied on the physician practice information, or PPI, survey data. And that looks at specialty specific practice costs, and has since for a number of years, going back to 2008. There have been additional survey efforts that were conducted in 2024 And essentially, because of a whole host of limitations, CMS said, thanks so much for this information, but we're not going to rely upon it for 2026. We're going to move away from this because of these limitations. So this is a significant update that's being finalized for 2026. Essentially, CMS has said, gosh, when we were looking at this previously, when we were thinking about practice expense, we were always thinking about services being rendered in the hospital as being rendered by physicians that also have an office location, that also have a practice elsewhere in the community that they're having to maintain, and the overhead and the costs associated with that. And what we have seen and continue to see is a rise in physician employment. And so CMS has said, the practice expense historical methodology for calculating practice expense didn't really take that change into account. And so they are attempting to do that now with this change in methodology. There have been a number of studies and things put out in the recent past, RAND studies, and also from MedPAC that talk about this being an issue. So the intent is to recognize greater indirect costs for office-based practices versus what is happening in the facility setting. So as you might be able to kind of quickly glean, this means that we will have some winners and some losers, as Marty mentioned. Services that are being done in the facility setting are going to take a hit as compared to services that are being performed in the office setting location. So types of specialties that are typically doing a whole lot of their work, or maybe even all of their work, in the hospital setting or in the facility setting are going to see more of an impact from this practice expense change. And so to do this, historically, again, the practice expense RVU component is a pretty complex calculation. There's a 19-step process that is outlined. If you're interested, it's out there in the final rule. I think it starts around page 700. But the practice expense RVU calculation takes into account two different types of costs. There is the direct component and the indirect component. The direct component is clinical labor, the things that are, I think, probably a little easier for all of us to understand. So supplies, nursing costs, things of that nature. Whereas the indirect, that's your overhead, those are your administrative costs, your billing fees, things of that nature. The indirect has a two-part allocator, is the way that CMS phrases it there. There's a two-part allocator there, and the work-based portion of the indirect allocator decreases by 50% in this final rule. So again, that means that your hospital-based specialties are going to experience some reductions that office-based specialties and office-based procedural services are likely not going to see. Those that are relying on time-based codes for billing may actually see an increase, a combination between practice expense and what's happening with the efficiency adjustment. So the allocation exercise that has historically happened essentially said there's not a material difference between the practice expense for this indirect overhead for those services being rendered in the facility versus the non-facility setting. And CMS is saying, we've seen such a shift in the industry, we've got to make an adjustment. So we're going to decrease that indirect work-based portion by 50%. So when we roll all of this up and think about this, in a practical sense, table DB7 in the final rule has a really good table that will kind of show you at a glance the impact by specialty. We've got an excerpt here. We picked a couple of specialties: family practice, hematology, oncology, and radiology, but the table is several pages long and covers a whole host of specialties. But you can kind of see for family practice, the overall impact is a positive 3%. When we look at the non-facility or the office-based services, that's a pickup, that's a lift of 6%. When we look at the services that a family practice physician might be doing in the hospital, we see a decrease of 9%. So the pendulum can swing widely depending upon the way that those services are being rendered, the place in which those services are being rendered. Similar story with hematology oncology. anything that's happening in the facility, that's going to see a double-digit decrease of 11%, whereas the services that are being rendered in the practice are 6% decline there. And then for radiology services, a 3% decline for facility-based services and a 1% for non-facility. A lot of those radiology services are intended and happening in the facility side of the house. So the overall combined impact there is negative. Next, I think, Lori, you're going to cover MIPS for us. So I will pass the baton to you.
Perfect. Thanks, Sarah. Yes, we will cover the merit incentive-based program and talk about some of the changes. Fortunately, within MIPS, we did not have significant changes. We had some clarity come from a couple of the areas. So from what was proposed to what was finalized is pretty steady. So we knew from prior year rulemaking that 2026 would require data completeness of 75%. What was up for grabs this go round was what it would be for 2027 and for 2028. And so it was proposed and ultimately finalized with no changes to hold at that 75%, meaning for MIPS quality that we would be reporting 75% of all activity across all payers. So it's at least helpful so that we know there was some talk at one point about that being increased up to 80%. And so every little bit, I think, matters when we're trying to aggregate the data and get it all complete across all patients, all payers. And so the hold at 75% gives us a little bit more predictability, which is helpful as we are planning for future years and participation. We are coming into 2026 with 190 quality measures. In the big picture, usually we end up with maybe 50, about 50 codes, 50 measures that are undergoing some sort of change. So this year was a pretty light year. They did finalize to add 5 measures, including 2 ECQMs. They made substantive changes to 30 measures, existing measures, and that's where we usually see it in the 50s. They removed 10 measures from the inventory, and there were QCDRs measures. They reiterated that those QCDR measures are approved outside of rulemaking, so they are not included in this count. 2 areas of note: they did not finalize changes to Q047, which is the advanced care plan measure, and Q141, which is the primary open angle glaucoma reduction of intraocular pressure measures. So those were 2 that had some material changes proposed that ultimately did not get finalized. 3 measures were also finalized with a slight modification from what was originally proposed. So if you report on breast cancer screening, colorectal screening, and screening for diabetes eye exam, 3 very common measures, you do need to look at those measures to make sure you are aware of those changes that did precipitate from the proposed rule. They also did lock in on the topped out measures in the definitions. So those are included as measures in a specialty set with limited choices, and a high percent of topped out measures that lack measure development, which kind of limits meaningful participation. Those are identified each year through rulemaking. And so this year they finalized 19 measures as meeting that topped out status. That includes 4 claims measures. So if you report via claims versus registry or through your EHR, those will be of interest to you. They did, as expected through the proposed rulemaking, carry forward with the decision to remove the phrase health equity from the definition. So now the definition refers to appropriate use, patient safety, efficiency, patient experience, care coordination, or opioid quality measure, and any outcome measure in that regard. So it does remove that health equity consistently throughout the measures that we'll talk about today. For the scoring of the administrative claims-based quality measures, they did finalize that to align with the benchmarking methodology for cost measures. Keynote here is that the finalization of this does impact this current performance year. So performance year 2025 and payment year 2027. So that is a current year adjustment. If you're keeping score and planning for your 2025 reporting, that will be of note. The median performance rate would be set at a score that is derived from performance thresholds and standard deviations that are applied to different scoring ranges, as you can see here in this particular table. So the key thing, remember, even though it's proposed and we're talking 2026, sometimes they will make adjustments to current participation and current performance year that are noteworthy as we evaluate all of their final rules. They did add some additional changes to the APP Plus quality measure set. It is an optional participation or selection for MIPS eligible clinicians, groups, and APM entities. It is required, though, for MSSP. So ACOs are required to report on this particular measure set. If a provider is selecting this measure, they have to report all measures in the measure set are required. You can't pick and choose, and you can't skip any. And then it is set to align with the finalized policies for MIPS quality measures inventory. So if they made a change in a MIPS quality measure inventory and that measure was included in the APP Plus quality measure set, that change carried over. And that includes the removal of screening for social drivers of health. Number 487 did come out in this final rule. When we're looking at cost, they making some changes really is how they are setting the impact or reporting to providers the impact of the cost measures. And so they established an informational only feedback period of 2 years for any new cost measure before it impacts your cost, which is helpful so that you get, I think cost is probably the least understood component of the MIPS quadrants. And so now if they implement a new cost measure for example, in performance year 2027, it would not impact scoring until performance year 2029, which is payment year 2031. So that gives providers enough time to get scored on the measure, get the feedback, get the breakdown on how they could impact that score, and hopefully make some changes in a positive way before it impacts payment in the big picture. They did also finalize some modifications to the total per capita cost, the TPCC measure. As you see here, specifically, they are excluding some candidate events that are initiated by APPs within a taxpayer identification number, so a 10, and an NPI, a National Provider Identifier combination. If all other non-advanced, advanced care practitioners, so non-physicians, in their group are excluded based on the specialty exclusion criteria. So there was some noise, I think, between complements of physicians and non-physician practitioners, and so they were trying to adjust for that noise. It does require the second service that's used to initiate a second candidate event to be an E&M, an evaluation and management service, or another related primary care service provided within 90 days of that initial candidate event, again by a 10 NPI within the same 10. And then it requires the second service used to initiate the candidate event be provided by a 10 or an NPI that has not been excluded from the measure. So a little bit to keep up with. It's hard for you to create an algorithm where you can check to see what's in and what's out, but they are trying to further refine how the cost scores are calculated based on some of those provider mix scenarios. With the improvement activities, they did finalize changes to the current inventory of 104 improvement activities. That includes it includes 3 additions, 7 modifications, and then 8 removals. Those 8 removals, you might recall, were previously suspended. Specifically, they also removed the Achieving Health Equity subcategory, and they added Advancing Health and Wellness. Again, just a switch as they were really changing the phraseology for those measures going forward. Related to the promoting operability, they did update the Protect Patient Health Information objective security risk analysis measure. It really is now including a second attestation, which is a yes/no attestation, as to having conducted a HISRA, a HIPAA security risk assessment. If you answer no, then there are 0 points available for the category. They changed the high priority practice safety assurance factors for electronic health records. So the SAFER measure, the guide measure there, and so that to ensure that it meets the 2025 SAFER guides. And then they also finalized a couple of new areas that you see on the right side of the screen, including a new or optional bonus measure for public health and clinical data exchange objectives. These are reported using the TEFCA, the Trusted Exchange Framework and Common Agreement measure. The measure suppression policy for MIPS under the PI performance category and the promoting interoperability category, they finalized those objectives. And that suppression of, they suppressed the electronic case reporting for performance year 2025. So again, another change to our current year. And that was due to the CDC pausing onboarding of new healthcare organizations, particularly at the beginning of the year with the DOJ and the transitions within the CDC. They suspended or paused adding organizations. So that suspended the ability to really use that particular measure. We still need to report yes or no to being an active engagement or claim an exclusion. If you report it, then you will receive full credit for the measure, and that's related to the public health reporting. If you don't report it or you don't claim an exclusion, then those 0 points will be important. So you need to really make sure you're working with your vendor as you're navigating this to report correctly for 2025. We still have the MIPS value pathways. We know that that CMS's goal is to push all providers into adopting a MIPS value pathway. They really are right now looking at 80% of making sure that 80% of the providers have an available pathway that they can follow. In the final rule, similar to the proposed rule, there is no set year as to when they hope to sunset traditional MIPS, but they continue to refer to their goal to do so. The includes the 6 proposed newly finalized MVPs, so diagnostic radiology, interventional radiology, neuropsych, pathology, podiatry, and vascular surgery all have new MIPS value pathways available to them for this year. They made modifications to all 21 previously finalized MVPs. Again, the majority of that was nomenclature changes to align with removing social determinants of health narratives. They confirmed and finalized that groups must attest to the specialty composition during registration, even if the group is a single specialty group. Before, they were trying to identify that based on claims analysis. So now a group is responsible for assigning their own specialty composition. Multi-specialty small group practices can still report as a group for performance year 2026. It's optional, but not required to report as subgroups. Remember, part of the plan was that you report as a group and then you identify your subgroups depending on your specialty and continue to get more refined groups of physicians and providers so they can make better comparisons across groups. That's their ultimate goal. And then finally, the QCDRs, the Qualified Clinical Data Registries, and the Qualified Registries will have 1 year after a new MVP is finalized before they're required to fully support that MVP. It takes a moment for the EMRs and the supporting technology to program, test, and catch everything up. At one point, that was intended to be within the same year. And so that got suspended, and now it will be a year before those MVPs must be available for those qualified EMRs. So that will wrap it up for MIPS. I think, Marty, it's coming back to you.
Let's talk about the new mandatory alternative payment model in the final Medicare physician fee schedule, the Ambulatory Specialty Model, or ASM. This is the second mandatory alternative payment model being implemented. Beginning January 1st, we have the TEAM model going live. That's the episodic payment model for certain surgical procedures that will apply to hospitals within certain selected CBSAs. Similarly, beginning on January 1st, 2027, certain physicians who provide certain types of services who are located in selected CBSAs will be subject to ASM, which is really, I think, best described as supercharged MIPS as we walk through these different elements of the program. So where this alternative payment model originates is in the MIPS cost category and CMS's development over the last few years of chronic condition episode-based cost measures. In fact, CMS has developed 10 such measures, as you see there on the left-hand side of your screen, with the most common chronic conditions. By having now a methodology for calculating how much it costs to manage an individual with certain chronic conditions, CMS now has the ability to compare how individual physicians manage patients with certain chronic conditions. And that becomes the launching point for this ASM model. Specifically, we're going to look at physicians who treat individuals with low back pain and individuals with congestive heart failure. So this new model that begins January 1st, 2027, so you have a year to ramp up, will be mandatory for selected participants. This is at the individual physician level. It's the MPI plus 10. So this is a APM that is applying to individual physicians as opposed to an entire group of a physician. Again, that's a difference here than MIPS, where, as Lori described, one can report as a group. This model will apply to individuals within a group. It is applicable to specialists that treat lower back pain and congestive heart failure. You see on the screen the lists of impacted specialists for low back pain. And again, it's going to be by specialty first listed on your PACOS registration. For congestive heart failure, it's only cardiologists who will be subject to this participation. Again, not all specialists who treat low back pain and congestive heart failure will be subject to ASM. Instead, it's going to be practices that are located in one of the selected CBSAs or metropolitan divisions. CMS estimates that approximately 25% of CBSAs will be selected. And as a result, about 25% of physicians who practice in these areas will be subject to ASM going forward. To find yourself in that new alternative payment model, you will have to have had 20 or more attributed episodes under that MIPS low back pain episode-based cost measure or the heart failure episode-based cost measure in the calendar year 2 years prior to the performance period. So if you had 20 or more episodes within the criteria of those cost measures in 2025, then you're going to find yourself participating in 2027. The episode then is initiated when a physician submits a professional claim for at least 2 separate services that are provided to a single beneficiary to treat low back pain or heart failure. CMS intends to release a preliminary list of selected participants by the end of this year. The final list of those who will be participating will be released in July 2026, which again aligns to calculation of MIPS scores because we then have the data from the prior year available. So in this case, we're waiting for 2025 utilization numbers, which will be used to calculate participation beginning in 2027, i.e., do you have the 20 plus attributed episodes under the cost measure? CMS received many comments regarding the ASM measure. And in fact, the discussion of the ASM measure goes on for a blindingly boring 155 pages, I have to admit, because they respond to each comment in detail. But as a result of those comments, they made only minor technical changes to the proposed rule. The methodology, if you are in ASM, again, I refer to this as supercharged MIPS, because if you are an ASM participant, you are going to report on specified measures across 4 domains: quality, cost performance, improvement activities, and interoperability, the same 4 categories we use for MIPS. Your performance then is going to be compared to benchmarks calculated using all ASM participants' performance. So take the example of, let's think specifically of heart failure. All the cardiologists who find themselves swept into ASM, then we're going to look and see what's the benchmark for those participants. And we'll look at their scores relative to each other. So if there are 100 cardiologists who find themselves within the ASM, literally we're going to rank those cardiologists 1 to 100 based on their scores across these 4 measures. So again, before, when we have MIPS, you're ranked in the sense that you get a payment increase or a payment decrease depending on your relative score, but that score is calculated relative to all participants in MIPS. Here under ASM, we've narrowed the comparison group significantly down to those specialists who treat a certain condition at a certain rate, at least 20 episodes within the 2-year prior performance period. And we rate them against each other. Then those that score the best and have the highest scores are going to see adjustments to their Medicare physician fee schedule payments at plus 9% in 2029. And those who perform at the bottom end are going to see negative 9% adjustments. Again, budget neutral program, right? We take from the poor performers and give to the good performers. And the only consolation I can offer you in all of this is that if you are an ASM participant, you are exempted from any other MIPS reporting requirements. So interesting, if you are a specialist within a group that has historically reported MIPS at the group level, your data apparently will still be included as part of the group's scoring, but your MIPS score, you're going to be subject to the ASM adjustment as opposed to your group adjustment as a result of its participation in MIPS. So basically, we're carving you out, treating you special because of your historic management of patients with these chronic conditions. The timeline, again, resembles MIPS. We're going to have a performance year. 2 years later, you have the adjustment to payment. So first performance year in 2027. We're going to see the adjustment take effect in 2029, and that's 9% both ways. So you can get a positive adjustment up to 9% or a negative adjustment down to 9%. That goes up in year 3 to 10%, and in years 4 and 5 of the program, it goes to 11%. And by the final year of this model, we're seeing 12% adjustments either way, based on performance by those subject to the mandatory participation.
Maria, can I add? I know
Please.
I'm curious. Some of our participants have experienced little trauma from when they did that through MIPS, where then they gave all of the exceptions, and at the end of the day, there was no big payout for early adopters because there was an easy pass for folks on the adoption. So it'll be easier. It'll be interesting to see how rigid they are in this launch.
Yeah, and given that they received all those comments and made so few changes, I would think that's indicative that they intend to go full board. If you are an ASM participant, you are regimented in the quality measures on which you report. It's those that appear here on the screen for heart failure and low back pain. And so they are either a claims-based measure. There's one claims-based measure for each. And then the others are going to be ECQMs or MIPS CQMs measures that you're going to be subject to. So no selection here. These are the measures on which you are going to report if you're in the ASM group. In terms of improvement activities, you're going to attest to completing 2 improvement activities, both connecting primary care to ensure completion of health-related screening of social needs, and then establishing communication and collaboration expectations with primary care using collaborative care arrangements. So as they want, not surprisingly, the idea here under improvement activities is better coordination between primary care and specialists in managing these chronic conditions. Both activities are weighted equally for purposes of calculating scores. And then for promoting interoperability, again, we see very regimented in terms of those PI measures on which you will report as an ASM participant. So how do we get to the final score? It's really quality and cost. And cost, I should have mentioned this, I apologize. The cost measure they're going to use is, of course, that episodic cost measure that provides the basis for measure, for the model itself. So quality is 50%, cost is 50%. You only get in trouble if you don't do improvement activities or promoting interoperability. So you have a scoring adjustment. So if you don't complete the 2 improvement activities, you're either going to have a scoring adjustment of -10 or -20. So don't do one of them, -10 points. Don't do both of them, -20 points. And for promoting interoperability, if you don't meet the requirements, that's another negative adjustment of 10 points. So it's relatively regimented how you get to your score. And given the hit you'll take for not doing improvement activities or promoting interoperability, I think it's relatively a priority to ensure that you meet those requirements as well. Then we do make some adjustments because different doctors have different patient panels. We're going to apply a complex patient scoring adjustment that's going to be based on HCC scores, as well as the number of dual eligibles that are in your patient population. And similar to a MIPS adjustment, that we will reference the median for each risk indicator calculated for the ASM participant data. So again, we're comparing you to the ASM participant group as opposed to the entirety of all MIPS participants. There is also an adjustment, a favorable adjustment, if you are in a small practice or a solo practitioner. So at the time that you are identified as an ASM participant for the upcoming year, if you are part of a group that has 15 or fewer clinicians in the practice, that's going to be a 10-point positive adjustment. If you are a solo practitioner at that time, it will be a 15-point adjustment. So again, trying to even the playing field to some degree there. So it will be, again, as you said, Lori, it's going to be interesting to see how we move forward with this. There's not a lot of preparation you can do. I mean, when we talk about the team model, because it's an episodic payment model around surgical procedures, hospitals have been focusing on how do we become more efficient, how do we do better coordination of post-discharge. But if you're one of these practitioners who is likely to have 20 or more attributed beneficiaries under the cost model, it's then just a question of how are we going to move forward in managing that patient appropriately to keep costs relatively low. Let's talk very quickly about changes to the Medicare Shared Savings Program. It's hard to believe this program has been around for more than a decade now. And CMS is really at the point of simply, adjusting minor changes that really align with other policy changes made to the Medicare physician fee schedule. Probably most impactful is the decision to limit the time for which an ACO can participate upside only. Currently, it's a 7-year period that you're allowed to remain in the MSSP without being forced to take downside risk. That's going to be now adjusted down to 5 years, but only for those ACOs that begin participating in January 2027. Also, CMS is going to remove the 5,000 attributed beneficiary requirement for the first 2 years of a participation agreement period starting after January 1st, 2027. Idea here is to allow smaller ACOs to get into the program They're finding many ACOs are being cut off and are not meeting the 5,000 attributed beneficiary requirement. So we let you in for 2 years at least, give you a time to build up your beneficiary base. If you can't meet the 5,000 requirement by year 3, you'll be, of course, the ACO would be discharged from the program at that period of time. There are also changes that are being made to the financial reconciliation process to account for that lower number of beneficiaries for those ACOs that qualify for that exception. Again, beginning in for performance year 2026, we have an expanded definition of primary care services. That's the formula used to determine whether a beneficiary is attributed to your ACO, and then you'll be responsible for that attributed beneficiary's total cost of care. CMS continues to expand what qualifies as primary care services as it expands primarily the world of care management services. And so it will then allow you to grab more beneficiaries as a result of that broader definition. Beginning also in 2020, actually beginning in 2026, CMS is going to require ACO participant list updates outside the usual once-a-year change request if you have certain changes of ownership to your ACO. And then beginning this year, in performance year 2025, an expansion of the extreme and uncontrollable circumstance policy, the EUC policy, to include cyber attacks. So up to this point in time, it's primarily been, hurricanes and other natural disasters. It's been now we're broadening it out to include the granting of extreme and uncontrollable circumstances for reporting purposes, to include both ransomware and malware attacks as well. Other minor changes made to the MSSP specific to the reporting quality reporting requirements. There's some effective for performance year 2025. So again, you're going to report in 2026, revising the definition of a beneficiary eligible for Medicare CQMs to improve overlap with beneficiaries assigned to an ACO, and also removing the health equity adjustment in the ACO's quality score. Interestingly, CMS is going so far as to revise the regulations which make reference to the health equity adjustment, instead changing the language in the regulation to refer to population adjustments back to performance year 2023 and 2024. If you are one that is nerdy enough to read the MSSP regulations, you will see that it's always cumulative, that each year as they change the program, will say for this period to this period, it's X. And for this period to that period, it's Y. Here they're going back in and actually amending the regulation to say that rather than referring to a health equity adjustment, it's referring to a population adjustment. Effective for 2026, they're removing the screening for social drivers measure to the APP plus quality measure set. And then for beginning in performance year 2027, some changes to the CAP survey, now requiring that there be CMS approved vendors, survey vendors who are using the web, mail, phone protocol. CMS determined that that's a more accurate CAPS data as a result of using that protocol, which results in a higher return rate is what they're identifying. So that's it for MIPS. And in fact, that's it for part 1 of the Medicare Physician Fee Schedule summary. Again, back next week with part 2, and addressing the remaining issues in the Medicare Physician Fee Schedule. So Jennifer, back to you to close us out.
All right. Thanks to our presenters, Marty, Sarah, and Lori. Please remember to stay on the line once the webinar disconnects to complete a short survey. Later today, you'll receive an email with their contact information and a recording of the webinar. Also, the slides and recordings for every episode of PYA's Healthcare Regulatory Roundup series are available in the Thought Leadership section of PYA's website, pyapc.com. While at our website, you may register for other PYA webinars and learn more about the full range of services offered by PYA. Please remember to stay on the line once the webinar disconnects to complete the short survey and post any additional questions you may have. On behalf of PYA, thank you for joining us. Have a great rest of your day.